Good evening, everyone, and thanks for the opportunity to come and speak. I was asked to talk about ways in which we undertake risk prediction in patients who are referred for cardiac surgery, and hopefully in the next probably 10-12 minutes we'll cover most of that. It's obvious to anyone that there's a huge degree of variability in perioperative risk in all patients. But in cardiac surgery, we see a lot of extremes. Obviously, the woman on the left, 40 years old, isolated mitral regurgitation, no other medical problems with normal left ventricular function, has a vastly different risk profile to the 85-year-old redo aortic valve with patent grafts and a left ventricle that doesn't work. So the question is how best to try to have some kind of meaningful way of predicting what patients' risk is so you can have the kind of conversation that Ivan was just talking about. So cardiac surgeons are relatively objective people. People often tell me that I only do 3 operations: cabbage, valve and other. So it should be relatively easy to try and quantify a lot of these variables. And that's been tried, and I'll go through a variety of different scoring mechanisms that are available. The other issue is that looking at raw outcome measures, as in the incidence of death, is a poor marker for quality of service delivery and quality of outcomes. So these scores are not only used for risk prediction, but they're increasingly now used in the public reporting of risk-adjusted outcomes. And the 2 major institutions that are doing that are the Society of Cardiac and Thoracic Surgeons in the UK and New York State in the United States. And in both of those places, individual surgeons and individual hospitals' risk-adjusted mortality outcomes are all available for public consumption on the internet. So there were a bunch of early scores in the late 80s, early to mid-90s, the largest of which was the Parsonet score. And then we moved on to the 2 main ones, which I'll talk about, which are the European classification system, or risk prediction system, and the American one from the Society of Thoracic Surgeons. And then there's one I just want to briefly mention at the end, which is the EuroSCORE, which is obviously an Australian scoring system. So the early ones were predominantly single centre. There was a couple of multi-centre risk systems which came out, but they're in relatively small numbers. The largest one was about 7,000, and that was in French, so no one else was interested. But things really got serious in 1999 when the group from the Papworth Hospital led the authorship of the EuroSCORE, the European System for Cardiac Operative Risk Evaluation. And that was developed from a data set of over 13,000 patients between September and December 1995. So it's only 3 months, or 4 months, sorry. And that was in multiple centres around the UK and Europe. And what they do is they, just for anyone who doesn't perhaps understand the process, they take a whole lot of patients' data and look at their outcomes, and then they try to work out which factors in those patients were associated with poor outcomes. Then you do a bunch of very fancy and complicated statistical things to work out what the weighting of each factor is in terms of determining that outcome. So the initial published score was an additive score, and basically 0 to 2 was low, 3 to 5 medium, and 6 and above was high risk. But that was pretty useless, to be honest. And then in 2003, the authors published what they called their logistic score, which became a much more valuable tool. And that essentially gives you a number, which is that patient's predicted mortality outcome for that particular procedure. And that's available online. It's now been superseded, and I'll talk more about that in a minute, but for about 8 years it was pretty well the major scoring system for cardiac surgery around the world. And these were the factors that they looked at. So these were the factors that, when they crunched all the numbers on that 13,300 patient group, these are the factors that came out, and then they used a second group of about 1,500 patients to validate the score to say that yes, it is a meaningful prediction in a prospective fashion. So most of them are pretty obvious: age, female gender, chronic obstructive airways disease, peripheral vascular disease, the presence of neurological dysfunction. Obviously previous cardiac surgery is a significant risk factor. renal impairment, active endocarditis. Critical preoperative state encompassed a variety of different things, including aborted sudden cardiac death, VT or VF within the previous 24 hours, I think, CPR within an hour of the procedure, balloon pump, inotrope requirement, a whole lot of things that made patients extremely sick and very likely to die. And then there were some cardiac factors, including the presence or absence of unstable angina, left ventricular dysfunction, recent infarct, pulmonary hypertension, and then procedural factors, emergency procedures, anything other than isolated coronary artery grafting, thoracic aortic surgery in the presence of a post-infarct ventricular septal rupture. So all of these, well, a lot of these are relatively obvious. Some of them perhaps not to people that aren't involved in cardiac surgery, but a lot of those last three are associated with extremely high mortality rates, even in the best patients. So as I said, that score stuck around for about 7 or 8 years, and then in 2011, the same group published their EuroSCORE 2, which is the current risk model, at the European Association of Cardiothoracic Surgery meeting in Lisbon, I think. And that was taken from a group of a little over 22,000 patients and validated in 5.5. So every time they've done this, the numbers are getting bigger. And the more numbers you have, the more likely you are to take out chance variation or non-significant factors and to make the statistics more meaningful. So the bigger the model, the more likely it is to be accurate. The other issue, and the reason that the EuroSCORE 1 was starting to over-predict mortality, is that it's from data from several years ago now, 12, 13 years ago, and anaesthesia improved, ICU improved, cardiac surgery stayed the same, and outcomes got better. So we needed to update it, and they also added in 2 new factors which hadn't been in the first model, one of which is a little bit poorly defined, which is poor mobility, and the second one is insulin-dependent diabetes, and they also drilled down a little bit more on functional status by means of looking at people's New York Heart Association and Canadian Cardiac Society scores, and those are NYHA scores, a score, of functional status for people with heart failure, and the STS Score is a score for functional status in people with angina or myocardial ischemia. So with that information now, the EuroSCORE 2 model is doing a reasonable job of being able to predict patients' mortality, but it still has a number of limitations. The first limitation is one I think Ivan alluded to briefly, which is because this is drawn from multivariate logistic regression analysis, small factors which don't have sufficient numbers get lost. Factors which we might regard, and many of you would probably regard as associated with very high risk. And the other issue is EuroSCORE 1 and 2 have been predominantly modelled on patients having isolated coronary artery surgery. Again, because of numbers, there aren't that many patients having arch replacements or some other more obscure procedure. And the key factors which are missing from the EuroSCORE model are multiple reoperations. So we know that the first reoperation carries a slightly increased risk in most patients, but the second, third and subsequent reoperations carry exponentially increasing risk, and those are not factored into the model, again, because the numbers of patients in that group, even though there's 22,000 of them, the number of patients in those groups having multiple reoperations is just too small. Liver dysfunction and coagulopathy don't factor. Presence of right ventricular dysfunction, not a factor. The EuroSCORE model does not incorporate weight, either underweight or overweight, and paradoxically we know that being underweight is a higher risk for cardiac surgery than being overweight. That may just be because most of our patients are overweight. And the presence or absence of cardiac arrhythmias. And again, probably one of its key failings is that it only looks at one outcome measure. It only looks at mortality. EuroSCORE is not interested if you live but have a very stormy course of multiple complications. It's not part of the model. They're only looking at mortality outcomes. The other major scoring system which is available around the world in terms of risk prediction is the STS Score, so published by the Society of Thoracic Surgeons in the US from their adult cardiac surgery database, which is contributed to by the majority of cardiac surgical units in the United States. Not all of them, but many of them. And this particular score was derived from patients undergoing surgery in the United States over a 5-year period, and they took 60% of that patient group and used it for developing the score and 40% to validate it. And so they ended up with over 750,000 isolated coronary artery grafting patients, over 100,000 isolated valves and 100,000 combined coronary and valve patients. Very, very large numbers. And with that data, because they had such huge numbers, they could look at multiple outcomes. So not just mortality, but also morbidity outcomes. And the ones they've highlighted in the model are stroke, new renal failure, the need for reoperation, mainly for bleeding, the presence of deep sternal wound infection, which is a major complication in cardiac surgery and up until about 10 or 15 years ago was associated with 50% mortality, and prolonged ventilation in the ICU, which is a little bit nebulous because different intensive care units tend to have different policies about extubation. But I think their prolonged ventilation is more than 24 to 48 hours, I forget the exact number, and as well as prolonged hospital length of stay. And that score is also available online at the website that's up on the screen there. So this is what it looks like. Basically, you go along and click on which procedure the patient's having, and then it goes through and asks you a series of questions, and it spits out a set of outcomes that you can see on the right of the screen there, which lists mortality, combined morbidity mortality outcome, all morbidity outcomes, and then the individual morbidity outcomes one by one, and each one gets a percentage. So these are the factors the STS score incorporates: age, sex, race, which is a significant issue in the United States, but also a significant issue for us in Australia, and I'll talk more about that in a minute. Height and weight, renal failure, obstructive airways disease, cerebrovascular disease, peripheral vascular disease, diabetes, hypertension, presence of immunosuppression, endocarditis, that critical preoperative state, term, heart failure, unstable angina or a recent infarct, arrhythmias, valve disease, non-elective surgery and their reoperative status. And this one does factor in first, second, third, etc. Redo. Again though, this score does have limitations. It only predicts outcomes for those key procedures in which they have data. So it does not predict outcome for aortic surgery, for anything else other than what's listed on the screen there. Isolated coronaries or valves, or combined coronary and AVR, mitral valve replacement or mitral valve repair. And again, it omits certain factors that came out and that didn't come out in the model: liver dysfunction, coagulopathy, right ventricular dysfunction and the presence of pulmonary hypertension. And all of those things we know are associated with a significant increase in the risk of mortality and morbidity in patients undergoing cardiac surgery. And the other problem with it is it's just a bit fiddlier. It takes a little bit longer to run through and fill in all the questions and get a score. And so we don't tend to use it. We use EuroSCORE in our unit, and not too many people outside the US are using the STS score for that reason. The Australian and New Zealand Society of Cardiac and Thoracic Surgeons runs a national database which is contributed to by about 2/3 of units in Australia, and that group's based at the Monash Medical Centre in Melbourne, and a couple of years ago they took the data from that and tried to generate our own score for Australia. Now they only had enough data to do it on isolated coronary artery surgery, but they were able to produce this score and published it in the Journal of Thoracic and Cardiovascular Surgery in 2009. And that's the Oz score, and that factors in some uniquely Australian factors like Indigenous or Torres Strait Islander status, which again we know is associated with worse outcomes for a variety of different reasons. Unfortunately, they haven't progressed this score any further. It's only been used in this one published paper. It's not being widely used, but it just goes to show we can do these things for ourselves if we put our minds to it. I just want to finish up with a little bit of an example about why these scores are not yet perfect and why we've got a long way to go, and why still the surgeon and the anaesthetist and other people in the team, the intensivists, cardiologists, sitting down and talking about a patient and trying to nut out what this patient's risk factors are and what we can do about it. Why that's unfortunately still the mainstay of our risk prediction. And this is a real case that some people in the audience will know. This was a 60-year-old man who'd undergone previous coronary artery grafting in 1986. He had a patent mammary artery graft to his left anterior descending coronary artery. His other two coronaries were occluded. He had an ejection fraction of 18% with an implantable cardioverter defibrillator in place. He then presented late last year. One of my colleagues operated on him and did a reoperative mitral valve replacement with a mechanical prosthesis, an operation that took 9 or 10 hours, and the man spent 2 weeks in ICU. Survived, got out of hospital, and then unfortunately represented in April this year with prosthetic valve endocarditis. My colleague was unfortunately away on leave, so I was asked to see this man as he had been bouncing in and out of hospital for 2 months basically with alternating heart failure and renal failure. His creatinine was up to 350. He was facing dialysis, which the renal physicians thought he probably wouldn't survive. So I asked the question, what is this man's risk? Obviously it's extremely high, so you punch his numbers and all his details into both those scoring systems, and the EuroSCORE tells you his risk of mortality is 61%, and the STS score tells you his risk of mortality is 27%. Which one's right? I have no idea. I would guess his mortality is somewhere in the middle, probably around 40%. Fortunately, I got away without having to operate on him. He's doing well, but it just goes to show that these scores are not yet perfect. There's a long way to go, but they're an aid and they help us with some of our decision making.